cord. Put that back like that. Put this like that. Come on. There we go. All right, so we're going to talk about the renal system this week, okay? And there were 3 PowerPoints that I posted. A smaller one that sort of reviews anatomy. If we have a chance to do it, we'll get back to it. If not, I will record it and post it again. But that should be mostly a review, if you will. But let's get into some of the other background and concerns for the renal system. And 2 of the most common causes of renal failure are diabetes and hypertension. And on the other hand, we know diabetes and hypertension can sometimes go hand in hand also. But if you end up with only one of them, both of them are going to be taking aim at your kidneys. And kidneys are kind of important. Other things that can go wrong, there are different ways kidney function can go wrong. Acute tubular necrosis, or ATN, is one of them. This is often caused by exposure to different drugs and toxic chemicals. It ends up causing necrosis of some tissues, other ischemic happenings, and then once you end up with this damage to the kidney tissues, again, you end up with decreased renal function. Now, I'm not saying that ATN is not, you can't resolve it or come back from it. Certainly some folks do. And that's the funny thing about kidney injury and kidney failure. There are some that are temporary, and given enough time, the kidneys can heal themselves and go back to highly normal function. But sometimes you just play a wait and see game. Are the kidneys going to repair themselves? Is the function going to get better? And sometimes you don't know for a while. But you may see in your medical charts that the patient has ATN, acute tubular necrosis, and it is a kind of kidney failure. Glomerulonephritis. Now, we know anything with an ITIS at the end means inflammation, and glomerulonephritis is inflammation of the glomerules, and it can be acute or chronic. Often shows up as enlarged kidneys on either x-rays, ultrasounds, or CAT scans. So again, inflammation, this acute glomerulonephritis is seen in children after a strep infection and or some viral infections. In adults, it's sometimes seen with a lot of our autoimmune diseases like lupus, diabetes, scleroderma, things like that. And again, after a strep infection is not uncommon also. Again, what happens is there's some sort of infection, antibodies are produced, the endothelial cells go into hyperdrive, leukocytes come in because there's been some inflammation and injury. This causes glomerulus scarring and decreased glomerular filtration rates. And again, on diagnostic imaging studies, you'll see enlarged kidneys. And the larger they are, usually the less effective they are. That's just a little diagram of what happens in glomerulonephritis. So what are some of our signs of glomerulonephritis? Well, very dark urine in the upper left-hand corner, dependent edema, dependent pitting edema, those big old ankles there. You see that urine sample there? What stands out when you look at that picture of that urine sample?
Foam.
Foamy urine, yes. And what does foamy urine usually make you think?
Glucose in the blood? Or
Uh,
no?
An aerobic bacteria. No.
Protein?
Isn't it proteinuria?
Proteinuria,
Protein in the
beautiful.
urine.
Yeah, proteinuria. Who said that?
Me, Jean.
John, good, excellent. You get a gold star de jour. You also end up with some hypertension, flank pain, facial swelling. They could be prone to nosebleeds and fatigue and headache. Those are those other two crazy things. But I always think, the dark urine, the pitting edema, foamy proteinuria, fluid retention. It can happen quite quickly. That's one of the things that are a little scary about it. And when you remember nephrotic syndrome we talked about in pediatrics, and so sometimes those two things go hand in hand. And again, that decrease in urine output or oliguria leading to the retention of fluids, and it can be fatal. They do liver biopsies and or ultrasounds of the kidneys. Again, they're going to see a enlarged kidney, and the good news is once it's recognized and once treatment's initiated, the vast majority of folks do recover.
Quick question, Carolyn. Did you mean to say liver biopsy, or did you mean to say kidney biopsy?
I meant to say kidney biopsy.
Just making sure. Thank you.
Thank you. Now, chronic glomerulonephritis is a little bit different. It's sometimes it's considered repeated episodes of acute glomerulonephritis, or sometimes it's just sort of a low-level issue that builds up over time, and so it's not always noticed initially. And the really crazy thing is where with acute glomerulonephritis, you get these big enlarged fat kidneys. With chronic glomerulonephritis, they shrink and shrivel up, which again seems almost counterintuitive on some level. You would think acute and chronic might look somewhat similar, and while it does in terms of other signs and symptoms, the physiology of the kidney itself looks pretty different. And again, you can see the increasing failure of the kidneys over time in the lab work, or the increasing and poorly controlled hypertension is another often sign of chronic glomerulonephritis. And just like with poorly controlled blood pressure from any source and increasing kidney failure from any source, untreated or uncontrolled can lead to stroke or seizures. And how I didn't notice that CVA, which is the old term for stroke, and why I didn't change that, I apologize. That should be stroke or seizures. what causes the seizures, do you think, in kidney failure?
High blood pressure?
Hyperkalemia.
Hyperkalemia.
The
So
erythropoietin, is that involved?
The magnesium levels.
So it's mostly the magnesium and the sodium levels that lead to the seizures. Hypo or hyperkalemia, potassium, that'll cause a quote unquote heart seizure or dysrhythmias, but doesn't often progress to neurological seizures. And certainly anybody who's had damage to their brain via a stroke is potentially prone to seizures also. But in renal failure is the electrolyte imbalances, the magnesium and the sodium most often.
So, but with that, did you say it was hypernatremia and hypomagnesemia? Which one was it? High or low for those?
I did not say, because right at this moment as you're asking me, Kristen, I can't remember.
Hypomagnesemia. I know
Thank you. And then
mag. I don't know sodium though.
I would, yeah.
Sodium, I
Thank
think it's both. I think both low and high leads to seizures. Other risk factors for chronic glomerular nephritis, well, repeated acute glomerular nephritis, diabetes, hypertension, lupus, good pastures, which is another autoimmune disease. And again, those shriveled up kidneys are a sign of chronic glomerular nephritis. Because of fluid imbalances, you're going to see that distended neck veins, congestive heart failure, pulmonary edema, confusion, and you're going to be looking at the typical blood work we look at for renal disease, BUN, creatinine.
So, Carolyn, is it correct to say that that's a right-sided issue?
It starts, yes, it starts as a right-sided issue and can lead to left-sided also. But the heart itself, so long as the hypertension isn't too extreme and hasn't created heart problems, it starts as a right-sided issue. That's good, James. And a lot of this is symptom management. And many of these patients require dialysis, which is a end-stage chronic kidney failure intervention. Pyelonephritis is an infection in the kidneys. So pyelonephritis goes way beyond your basic urinary tract infection. This is literally infection within the kidneys. And it is a big deal. It's more common in women than in men. Sometimes it is associated with obstruction, blockages out of the kidneys, like tumors, prostate enlargement, things like that. But, and again, we've talked about this, you know, once the kidney makes the urine, it's supposed to leave the kidney. That's what the ureters are for. And that's supposed to go down to the bladder, and then it's supposed to exit the body. And when it doesn't do that, and God forbid it blocks up into the kidneys, that's a problem. So yes, obstruction can lead to pyelonephritis and create problems like that. Okay, why are you doing this to me? So oftentimes, you know, those typical signs of infection, fever, chills, increased white blood cell count, bacteria or pyuria, you're seeing white blood cells or both white blood cells in the urine as well as bacteria in the urine. and flank pain. If you'll think back to your head to toe physicals, we may have talked about costovertebral angle pain, CVA tenderness. Do those words ring a bell with anybody?
Yes.
For those of you that aren't remembering it as clearly, CVA tenderness is where sort of the ribs join the spinal cord, and that's just about where the kidneys sit also. If you gently pound on somebody's back at that juncture and they say it's tender there, that's CVA tenderness, and that's often a sign of pyelonephritis. You'll also see an increased white blood cell count in the blood. You're going to send a urine culture and sensitivity, because even though the infection is in the kidneys, you're going to see, you're going to grow out a culture from the urine as well. One of the most common imaging studies for kidneys is the ultrasound. They can tell a lot when they look at ultrasounds of the kidneys. This is a really significant infection and will often require admission to the hospital. We know that most localized urinary tract infections are treated in the outside community by mouth antibiotics. And it's not until unless somebody's got some immune system disorder or has failed outpatient antibiotics, or or it's no longer a localized infection and become more of a systemic issue. But it's not unusual for pyelonephritis to be admitted for IV antibiotics. Will they rest? And it's a fairly long course of antibiotics as well. Can easily be up to 2 weeks. If it is not treated effectively and thoroughly, it progresses to chronic kidney disease and ultimately end-stage renal disease. And then we have a big umbrella of acute kidney injury. And I suspect you have all read in one of your patient's charts in the last year or so, a patient who's had AKI. And what this means is there's some acute injury to the kidney, and it can be multifactorial. And again, it's hoped that the kidneys are going to rest, get better, and the patient will progress without a long-term impact. But at that moment, while the kidneys are not functioning to 100%, you don't know whether they're going to recover or not. 2 most common causes of AKI is renal ischemia. Again, if they're not getting perfused with the amount of blood they think they deserve, and or a nephrotoxic injury, some exposure to some toxic agent that damages the kidneys. Again, the kidneys are full of blood veins and arteries. There's a lot of circulation going on there. Their whole purpose is to get exposure to the blood and to weed out the toxins and to send out and to keep the good stuff in. So they are highly vascularized organs. And I've talked about it before. Anything that's disrupting the arterial blood flow to the kidneys can potentially cause acute kidney injury. So let's talk about what are some of the things that can cause decreased blood flow to the kidneys.
Obstruction.
Where's that obstruction come from?
Well, you could have a sort of a traumatic injury that would preclude fluids getting to the kidneys.
That's true. Yep. Does anybody want to say anything more on that obstruction? What's the main highway of arterial blood to the kidneys?
The liver.
The artery itself. What's the artery?
Oh, the artery itself. Oh. So go ahead.
Go ahead.
Y'all are going to kick yourselves if once it's that question's answered.
Is it the descending aorta?
Oh, you're getting way too fancy, Jonathan.
Portal?
That goes to the liver.
A renal artery?
There you go. The renal artery. Told you you'd kick yourselves. Where does the renal artery, so the renal artery goes, there's a left renal artery and a right renal artery because we have a left and a right kidney. Where does that renal artery come from? What's the main artery that the renal artery branches off of? And I'm talking main here, man.
The aorta?
Yes.
That-
Yes. So if you have a dissecting aorta or you have an aneurysm of the aorta and that's anywhere near that where the renal artery branches off, that can impact blood flow to the kidney. So that's another reason why ultrasounds are done. And you worry about where that, I mean, we worry about a dissection in an aneurysm anyhow, but the closer it gets to the renal arteries, the more risky that dissection and aneurysm is. They take them all seriously, but they really take those seriously. And again,
Hey, Caroline, if a patient has a dissected,
I'm sorry, try that again. You were coming in and out, James.
if the patient is dissected, are they able to save that patient? And if so, how?
So I got the last part, if they save the patient and how, but I didn't hear the first part. I'm so sorry.
If the patient has a AAA and it's dissected, are they able to, repair it? Can they save the patient? And if so, how do they do that?
So, obviously that is especially if it's increasing in the moment, that is an emergency, but there are a couple different ways. They can go in and there are two most common ways of treating a dissection is either opening the patient up, and that's usually like stem to stern, from the sternum right down to the pelvis, and going in and replacing part of that aorta, which is a very risky procedure because you've got to block it off to anastomose the part you're removing and the part you're putting in. Nowadays, most dissections, they try very hard to do minimally accessed, and it's done through the femoral artery. So you take a piece of, and I don't know what material they're using these days, I'm sure it changes, and take a length that's going to reline the aorta, and they're able to attach it up high and attach it down low, so it reinforces that area of dissection. And so when you attach above and below, you sort of cut off that area of dissection that's causing the transluminal split. And if someone's actively leaking or bleeding from a dissection or an aorta, again, those are the two most common ways. You can either open them up if it's a big leak or bleed, or do it from a minimally accessed perspective. But again, the closer this happens to the renal arteries, the increasing need to do an open procedure. And I know they're working hard on developing the tools and the methods to treat those with minimally invasive techniques also. But I still believe as the closer a dissection or an aneurysm is to a renal artery, the greater the chance you need an open procedure. Is that helpful?
Very helpful. Thank you.
You're welcome. There are, it's no secret that there's a lot of stuff we do in medicine that I just sit there and go, God, thank God there are people who are smart and are so creative and they just think of these ideas and then figure out how to make them real. It's unbelievable. So again, acute kidney injury is a really big umbrella term. It could be from multiple different perspectives, multiple different kinds of injuries. I wasn't done talking about how do blood flow to the kidneys. So we talked about obstruction. We talked about those diseases of the aorta can cause decreased perfusion. What else can cause decreased perfusion to the kidneys?
Heart failure?
Heart failure, yep. And again, if particularly if they're shocky, Jonathan, and they have a prolonged period of hypotension. If somebody's blood pressure is in the 60s or the 70s for 15 or 20 minutes, again, the body is going to vasoconstrict the less critical areas so that the heart and the brain get the majority of the blood flow, if you will. And that pisses those kidneys off, man. So again, hypotension, whether it's caused by hemorrhage, fluid volume deficit, congestive heart failure, right? Any prolonged hypotensive period can be the root of acute kidney injury. This is a big deal. I mean, surgery is not the only thing, but probably one of the most important things that anesthesia does during a surgical procedure is monitor the blood pressure. Because 5, 10, 15 minutes of a 60 or a 70 over whatever is enough to cause kidney injury. And you hope the kidneys come back, but you just don't know. So again, first they end up with some level of damage, the failure becomes more pronounced, and you need functioning kidneys. You need functioning kidneys. I'm just going to full stop there. So this isn't recent, as you can see. It's from 2014, but it's still sort of significant that hospitalized patients who suffer acute kidney injury, long-term survival is not great. It doesn't matter what level of acute kidney injury it is. You're still only looking at a 50 to 60% survival rate after a year. So again, I show you this graph in an effort to encourage. This is why we monitor blood pressures. We watch urine output. We are ever vigilant for signs of decreased kidney function and the need to prevent injury to the kidneys. Kidney injury can be classified in 3 different ways: pre-renal, intrarenal, and post-renal. Pre-renal means not enough blood is getting to the kidneys. There is something happening outside the kidneys before the blood gets to the kidneys that's making the delivery of arterial blood to the kidneys difficult. That's pre-renal. So we talked about these: MI, congestive heart failure, hemorrhage, things like that. Intrarenal, it's happening inside the kidneys. And this is usually either because of trauma to the kidney directly or some exposure to a toxic agent. Think drugs, think other things, infection, and diabetes. Because again, we know diabetes impacts the kidneys themselves. And then post-renal injury is an obstruction. Big old kidney stones, big old prostate, trauma to the ureters, blood clots. So pre-renal is decreased blood flow to the kidneys. Intrarenal damage to the kidney tissue itself. And post-renal can't get the urine out, and it ends up sort of poisoning the kidney tissues. Does that make sense? I'm going to go with I hope so. And again, here are some of the most common common causes of kidney injury by type, if you will. And I think we talked about most of these. Somebody's in the waiting room. I have to bring them in. One moment, please. Okay. Sorry about that.
Cool.
Okay. So an older adult with benign prostatic hyperplasia, or BPH, is at risk for post-renal type acute renal failure. I heard Eugene said that is true, and I agree with that. Again, that's a blockage, a big prostate that's keeping the urine from flowing out. Now that's even below the bladder. So the bladder's getting fuller and fuller, the urine's backing up into the kidneys. And again, just even more. So burns, what kind of is a burn a pre, intra, or post-renal problem, do you think?
Pre.
Great.
Pre-renal, right. Shock,
Pre.
trauma, you need to know a little bit more because it could be to the kidney directly, you know, kidney laceration or something like that, or it could be damage to the urine flow process, or it could be a hemorrhage, which is causing low blood. So we need a little bit more information before we can classify trauma, but nonetheless. So I always mention vancomycin and gentamicin because these are such common antibiotics. We are giving these two antibiotics, I feel like, all the time. If I had a nickel for every time I've given either of these two, I could pay all our tuitions without a blink of the eye, man. And they are extremely nephrotoxic if not done properly. And it does, and the funny in quotation things, or the ironic thing is, it's not just the dosing, but is also how fast you give them. So you might have the right dose calculated, yay us, but if you give it too fast, you're still causing kidney injury. And again, you don't know if the kidneys are going to recover. Some do, some don't. So when you're giving vancomycin and gentamicin, you check drug blood levels. Why do we call it a trough level again? Or what do we mean by trough level, do you think?
It's when it's at the lowest in the system.
When the concentration is lowest in the system. So when would that be?
When you wake up,
Not when you wake up.
Depends on the half-life of the drug.
Katie, what did you say?
Not me, it's probably Linda.
Sorry, Linda, what did you say?
I said it depends on the half-life of the drug.
Maybe prior to administration?
Be before the next dose.
There you go, prior to administration. So just before you're going to administer the next dose is theoretically when that dose is, the circulating level is at its lowest. So it's your responsibility to know, is my patient due for a trough level before I administer this drug? And if it hasn't been done yet or hasn't been done in a couple days, you need to check to make sure, was that a mistake or are we waiting for some other reason for a different time frame? But if you don't, again, after probably your first 2 doses, maybe 3, which again could be in the same day, could be a day or 2 or 3 later, depending on how it's ordered. If you don't see a trough level, ask when it's going to be done and if they want it done this time around. And that's because we should be looking for that. We also need to check on, our ongoing BUNs and creatinines. Is there been any significant change to those levels? Does it seem to correlate with when the drug started and how long they've been on it? And again, just because you have the right dosage, you can screw it all up by giving it too fast. So your vancomycins, your gentamicins, they certainly do not get pushed. Certainly do not get pushed. But you also don't even speed them up because you're running late on your triples and you only have 1 or 2 access or whatever the issue is. You need a lot of time to give these. They're not hurryable. They don't do well when they're hurried. So the other thing is about acute kidney injury, it can be a couple days before you see the effects. The event happened a couple days ago, and it's 2-3 days out that all of a sudden you're seeing, the urine output is decreasing. The creatinine is up. Wonder what happened a couple days ago. So you really kind of need to, that's why I like to really know a little bit about a patient's history. And I get concerned about when they are, especially if they had a procedure, been in the OR, any sort of potential hypotensive event. One of the first things you'll see is a decreased urine output. So again, most folks do not have an indwelling catheter, but this is why keeping track of urine output is really important. And you've been around enough to know that those I&O numbers are not exactly always numbers you can take to the bank. between patients peeing and not putting it, not into a hat, between people dumping the urine, between us not checking regularly and the patient dumping the urine. Getting accurate I&O numbers can be a challenge, but again, with certain patients, it's really important. Then, so that oliguric phase and then the diuretic phase. Diuretic phase usually implies the kidneys are recovering. But they've lost, or at least temporarily lost, we hope, the ability to concentrate urine. And they're going to have really high volumes of output. Hopefully toxins are coming out with that. But they're losing a lot of volume, so we need to watch to make sure they don't get dehydrated during this period. And I've often said that, and it's not that there are different kinds of renal failure, but where the kidney is injured does make a difference. There are people with severe kidney failure that still make urine. It's not concentrated, it doesn't have a lot of toxic waste in it, but at least they're getting rid of excess volume. On the other hand, there are people that not only don't get rid of toxins, but they don't get rid of excess volume either. And those are people who not only do they have the buildup of the toxins, but also have fluid overload as well. So just because they're putting out urine, sometimes in copious amounts, doesn't mean it's quality urine. It can still be kind of crap. So you have to be aware of that. And then hopefully slowly but surely they start filtering out the toxins, retaining the fluid as necessary, and you get back to an appropriate balance. Your BUN creatinine levels come back to within normal levels. The urine is both appropriately concentrated and full of toxins, but this can take quite a while in terms of recovery. So again, almost 70% of folks have that decreased urine output as one of the earliest signs. Decreased urine output, retention of fluid is going to lead to edema. If toxins are left in the body, between those electrolyte changes and the buildup of the toxins, you're going to have changes in mental status. That right-sided fluid overload problem becomes a left-sided fluid retention problem over time, leading to heart failure. Nausea and vomiting, again, from the buildup of the toxins, as well as the excess electrolytes. Pruritus, patients with renal failure get what they call a uremic frost. They literally get this like frosty look on their skin as uremia starts seeping out of their skin, and it almost looks like frost, and it is very itchy to them.
And it smells.
I wouldn't have said that, but I'll take your word. I don't, I do what I call my obligatory sniff in the morning, and then I try not to breathe through my nose again until I leave the hospital, unless I have no other choice. You rarely run into pleasant smells in a hospital.
Yep.
Anemia, again, where's the anemia come from?
Inability to produce erythropoietin.
The erythropoietin, therefore you can't make red blood cells. Beautiful. Tachypnea, yeah, fill somebody up with fluid, they're going to get short of breath and cool, pale skin. So that's what acute kidney injury kind of looks like over time. So we're watching blood pressure and heart rate. We're doing strict I's and O's. Go for a low protein diet. low potassium, low sodium, because the excess potassium, sodium are excreted through the kidneys, and so if the kidneys aren't working, they can't get rid of excess, so don't give it to them. And then a general appearance is really important. Bruising, edema, skin color. Again, kidney's a big deal, potassium's a big deal in patients with kidney failure. It's the kidneys that get rid of it. And if they're not working, you got problems. And we know what happens, whether you've got a low or a high potassium is not good for the body. And why do we go low protein?
Because protein in the blood pulls water and they're already going to be retaining water.
And protein, also excess protein stresses the kidneys. So we want to try to keep things easy on them so they can kind of rest and recover. Both those reasons. Hyperkalemia, weakness, lethargy, muscle cramps, paresthesias. You know me, I'm not a big deep tendon reflex checker, but they're going to be hypoactive for those who are. And then the big one, dysrhythmias. Hyperkalemia, big, tall, peaked T waves. Again, we haven't gotten to EKGs yet, but these are the sorts of things that we look for when we are reading EKGs. Wide QRSs, the higher the potassium get, the worse things get. Prolonged QT wave is very ominous. They end up bradycardic. And you don't have to be above a 9 to preclude cardiac arrest with hyperkalemia. I've seen plenty of people go into ventricular tachycardia or VFib with potassiums less than 9. That's sort of like your assured outcome with a K of 9. How do we treat hyperkalemia? Well, you can give calcium gluconate. The calcium ends up sort of competing with the potassium and blocking it out. Sodium bicarb is less, it's still on the list, but I don't see that being done as often. If you think back to treating DKA and how potassium works with the cells, by giving insulin, you give the insulin to force the potassium back into the cells so that your circulating potassium goes down. But most of these folks don't need the insulin, and you risk hypoglycemia by giving them insulin. So you give them extra glucose. The insulin does its job driving the potassium into the cells, and then you give glucose so the patient doesn't get hypoglycemic. Kexalate, usually given by mouth, binds potassium and they poop it out. Can also be given via enema if the patient's not able to swallow. Lasix. We give Lasix, I'm not going to say all the time, but we give Lasix all the time, right? We know that somebody's on Lasix, they're going to be excreting potassium. Now, this seems a little crazy that the kidneys aren't working great. That's why they're holding on to potassium. So we're going to give Lasix, which is a loop diuretic, which might stress the kidneys to get rid of the potassium. But we do it. But again, you need to watch the fluid balance to make sure they don't.
Julian,
Yeah.
Musia is in the waiting room again.
Okay. Thank you. How did I do that last time? Does anybody remember? Right there. Thank you. So Lasix, got to watch the fluid balance when you're giving the Lasix, but again, we know that Lasix does impact potassium. And then if all of those fail or we don't have time for those, emergency hemodialysis. It's one of the reasons people with chronic kidney disease or severe acute kidney failure end up on hemodialysis. We need to write their electrolytes. And again, back to acute tubular necrosis. This can be caused by pre-renal injury, again, nephrotoxins. The kidney tubules are what's damaged here. And in most cases, patients who have ATN are not making any urine. Patients with ATN usually make urine. So fluid balance is not as big an issue with ATN, but it's not quality urine. Again, it's not excreting the toxins, and it's not great at keeping track of electrolyte balances. Whereas pre-renal acute kidney injury, those patients stop making urine and have decreased urine output. So when we think somebody's been hypotensive, when somebody's having that first sign of decreased urine output, usually the first thing we do is to give them a fluid challenge. Let's give them a bolus of fluid and see how the kidneys respond to it. You also want to take a look at the medications to make sure there's nothing on the list that's stressing the kidneys. You believe somebody's got compromised renal function, you want to avoid diagnostic imaging contrast, IV for the most part. Usually the stuff that you drink is not as big an issue, but the IV contrast is very nephrotoxic. And again, keep an eye on your electrolyte balances. Dialysis, again, that's known as a renal replacement therapy, an RRT. That's where you really are not able to manage high levels of potassium, excessive fluid overload, severe acid-base imbalances related to kidney failure, and things like that. It can also help facilitate getting rid of very specific toxins. So you may try that rather than some of the other therapies. And just because you start dialysis does not mean it's necessarily a lifelong therapy moving forward. Sometimes you provide dialysis to truly give the kidneys a rest and to keep the patient safe while the kidneys are healing. And once they come back, then we won't need dialysis on a long-term basis. Renal cells do recover, but again, it's not always been clear to me, and it's not overly clear in the literature why some kidneys recover quite fully and others are compromised on a prolonged chronic basis. All right, why don't we take a 10-minute break? Let's come back, well, let's take 15 minutes. Let's come back at 11:10 a.m., 11:10, and I'll start that second PowerPoint. And if you have any questions, I'll be around, okay? And I am going to stop the recording just so that it's easier for you guys to watch. Typically, chronic kidney disease is a relatively slow issue. It doesn't happen overnight. But when after 3 months after an incident or a while, you don't end up with improving kidney function, it's determined to be a chronic problem. And it's in different stages. It's, not all chronic kidney disease looks the same. In the early stages, creatinines may actually be normal, but you're going to start seeing proteins and red blood cells in the urine if you chose to look for them. And by the time, once you start getting changes, chronic changes in your creatinine, you've already got significantly decreased glomerular filtration rates. Don't start with me, machine. Okay. So stage 1 of renal failure kidney disease is, your renal function, your reserve is not what it should be. You're not actually seeing a change in the levels of toxins. Again, you're not really going to see a change in the spot creatinine levels you do. The way you do this is to do a 24-hour urine study for creatinine clearance. If you are doing a 24-hour urine study, you have the patient void, then you start the clock and collect every urine sample from that point on. The sample is kept either in refrigerator or on ice. It needs to be kept cold, if you will. But again, in stage 1, what you're seeing is that the good nephrons are compensating for the ones that aren't carrying their weight, if you will. So outwardly, there may not be a lot of change to blood work and things like that. Stages 2 to 4, now we're going to start seeing some changes. The good nephrons are being overwhelmed. You're going to see an increase in the creatinine. Patients are going to feel fatigued. They're going to be weak. They may be complaining of some headache and nausea. And this gets progressively worse as they advance through the stages. End-stage renal disease and stage 5, those are synonymous, but you will more than likely see ESRD or end-stage renal disease as the documentation in the medical record. They really haven't, it's funny, the earlier stages they still call stage 1, 2, 3, 4, but once they progress to stage 5, they switch over to end-stage renal disease. And at stage 5, the patient needs renal replacement therapy, and that is either dialysis of some sort or a kidney transplant. And at this point, the patient has significant, obviously, a significant decrease in renal function. Toxins are building up, and the patient really doesn't feel well. And here is, this is the National Kidney Disease chart of the different stages. This is what the glomerular filtration rates are at the different stages. Again, in the medical record, you will see a calculated GFR, and so that is an estimate. It is not an actual direct value of that patient, but it is a measure, if you will. So some of the nursing diagnoses we use for these patients are excess fluid volume. Again, related to poor fluid excretion as evidenced by edema and weight gain. And again, not all patients with chronic kidney disease are oliguric. Some do make urine. It's just poor quality urine. Imbalanced nutrition. These patients are both very fatigued and therefore often don't have a lot of energy to eat, but they also don't feel like eating. Those toxins that build up really cause nausea and really suppress patients' appetites. Activity intolerance could be from shortness of breath, fatigue, both things, shortness of breath, need for increased rest. So those are not uncommon nursing diagnoses for folks with chronic kidney disease. So if patients are hypertensive or patients have diabetes, this is why we have spent so much time this year talking about how do we mitigate diabetes and hypertension. Why is it so important to teach our patients what good control looks like? Because of the risk of kidney failure from both of those, amongst other issues, of course. And if it wasn't well controlled prior to, never stop trying to get a better handle on it. Ditch the smoking. I don't have to say that again, but I will. Sort of ration protein, because protein puts stress on the kidneys. We use phosphorus lowering drugs because, again, phosphorus is excreted through the kidneys, and so if they're not working, phosphorus will get high. You end up with hyperphosphatemia. But on the other hand, they need calcium replacement because calcium, we don't want it to seep out of the bones. We want it to stay in the bones. And because of this, hyperparathyroidism impacts the calcium levels as well. We've talked about the chronic anemia or the anemia of chronic disease and the anemia related to renal failure. So we start erythropoietin replacement on these patients, especially when the hemoglobin gets below 10, to help stimulate whatever erythropoietin they can produce and to make sure that we maintain their oxygen carrying capacity as long as possible. We've talked before about how important the kidneys are in maintaining acid-base balance. They are one of, what's the other system besides the kidneys that has so much to do with metabolic?
Respiratory.
The lungs, if you will, the respiratory system. That's true. So when the kidneys go, the lungs don't have that partner, particularly with the metabolic issues, to help mitigate pH issues. Part of that, part of what we do is patients take big old bicarbonate tablets, sodium bicarb tablets actually, to help maintain the right pH. And then that question of dialysis. The interesting thing is, and I've mentioned this in class before, but I'm not going to let that stop me from mentioning it again. The kidneys have a ton of overlap and compensatory opportunities within their cells. They start thinking about dialysis or renal replacement therapy not until the kidneys are at about 90% gone, or they only have 10% of normal function left. So at 20, even though a patient may only have 20 or 30% of their kidney capacity, people are still not pushing for dialysis at that point. So it goes to show you how much compensatory activity and sort of duplicative opportunity there is. It's also why you can donate a kidney and still be in perfectly good health, and all. Another reason for the calcium issues is because the kidneys stop converting vitamin D to its active form. And we know vitamin D is necessary for calcium levels. And as I said, that's also impacts the parathyroid hormone as well. So we know diabetes, hypertension, we talked about glomerular nephritis. HIV brings its own nephropathy as part of its process. Polycystic kidney disease often is a concern or precursor to chronic kidney disorders. Chronic infections, poorly managed infections, obstructions. And the incidence of chronic kidney disease in our Black population compared to white Americans is almost 4 times that. And a lot of that has to do with diabetes and hypertension and all of the other access issues that come with racial discrimination as well. So some of these things we talked about: malaise, weakness, fatigue, that's always kind of one big category. Neuropathies are common with kidney failure, congestive heart failure, particularly when they're allouric. Anorexia, nausea, and vomiting come from the buildup of the toxins. Seizures because of oftentimes the alterations in electrolytes. Constipation with kidney failure. Peptic ulcer, oftentimes, again, physiologic stress on the body. Diverticulosis, anemia, the pruritus again, even jaundice is a problem. Headaches, edema, decreased ability to concentrate urine. So again, it can be either polyuria or oliguria. People with chronic kidney disease who make urine, it's not quality urine. Not a lot of toxins, often not concentrated. Increased levels of BUN and creatinine, anemias, increased blood pressure. So again, chronic kidney disease represents a bit of a continuum where the last stage, stage 5, is or end stage renal disease are synonymous, and end stage renal disease needs renal replacement therapy, which at this point in time is either dialysis or a kidney transplant. So we're teaching a patient who has chronic kidney disease and they're preparing them for hemodialysis. Which of the following things should we include in our teaching? Hemodialysis will restore your kidney function. Hemodialysis will restore the hormonal function of your kidneys. Your diet will be unrestricted once hemodialysis begins, or hemodialysis returns a balance to serum electrolytes.
D.
Say that again, please.
D.
Is that B as in boy?
D is in dog.
D as in dog. Oh, I like that much better. Thank you. Yeah. So in most cases, once you've been determined to have chronic kidney disease, hemodialysis is a lifelong therapy unless transplant is executed, or let's see, until a transplant is executed. It does not cure your kidneys. It doesn't change hormones. And you certainly cannot eat whatever you want once you start hemo. You're still on a highly restricted diet, but it will return a balance to the serum electrolytes.
I have a question.
Yep.
When considering who gets a kidney transplant, I'm sure it's like a very complicated process, but do they take into consideration how likely people are to be compliant with like their diabetes or their hypertension, for example? Because if they get a new kidney, they could just ruin that kidney again.
Well, who was that, Allie?
Robin.
Robin, hi.
Hello.
If you look at the criteria, or the articles that talk about criteria, yes, that is supposed to be part of the discussion and assessment. But I hate to say but, because I've never been part of those discussions. That's not the work I've done. On the other hand, I will say but. When I look from afar at some of the cases who have received transplants of any organ, if you will, heart, lungs, liver, kidney, whatever we're transplanting these days, there are some choices that confound me. And we could talk. I could talk for hours on why and how I think that is, and I suspect many of you can talk for additional hours from your perspective as well. But let's say to shorten today's discussion, I think in general, we are a funny society. Again, ironically funny, not hysterical funny. We were founded on very puritanical values, and in many respects, we have a ferocious perspective of right and wrong. Sometimes it's held societally, sometimes it's held individually. But yet we are often not really good at making other people's decisions for them. We believe in personal freedoms as sort of a priority. I'm talking in generalizations here. So we tend to give people and resources a chance to succeed. Does anybody understand what I meant by that whole conversation? Does anybody have any other comments or personal experiences or any perspectives they'd care to share?
Is it just like benefit of the doubt?
But, I think it's certainly folks have had assessments by social workers, if not behavioral health therapists. Maybe they've articulated a want to change. Maybe they've demonstrated the ability of change for some seemingly short period of time, and maybe their condition is evolving so quickly that a decision needs to be made sooner versus later. So part of it may be benefit of the doubt. I think it's probably very tough, and me in particular, speaking for me, I probably talk a tougher game than I would ever be able to execute if I was in that role. But that's me. And so again, while again, this is Carol Ann Wetmore speaking. In general, and I'm not talking about the science here. The science is solid. Transplants work. but from my sort of socialist perspective that I hold on certain things, where I want to get the greatest value for the greatest number in the population, if you will. I'm not a huge fan of solid organ transplants. They're very expensive. The average cost for a transplanted organ over the lifespan of the individual who's received that organ is about $5 million per organ. And I think that amount of, and that's all the drugs, all the additional health care. It's not just the procurement of the organ or the insertion of the organ, but that's a lot of money. And I think most towns would love to have $5 million to expand to an all-day kindergarten, or to provide better nutrition in their school system, or to make some other infrastructure change. But that's Carol Ann Wetmore, the socialist, talking. And as I say, it's easy for me to talk about that in a theoretical perspective from my place as an academician, and I'm sure I would fail miserably implementing that when I was looking into the face of someone needing a transplant. I have no doubt I would collapse like a house of cards. And I'm sure you have no doubt that I would collapse like a house of cards. I can't even, I'm changing quiz tests to make it easier for everybody. I have no backbone. I have no spine. I'm an embarrassment. But transplants are expensive, man. Again, does anybody have any other comments or experience or anything they'd like to speak to? All right. Feel free. Don't leave me out there. It's okay. So again, we worry about potassium in particular, calcium, fluid management, the anemias that come with chronic kidney disease, hypertension. As fluid builds up, it not only ends up in the lungs, in the periphery and all, that you get a lot of pericardial infusions, you get a lot of pleural effusions, and you end up with a higher incidence of pericarditis, which is inflammation of the pericardial sac, which further complicates cardiac function. Again, the peripheral neuropathies can be fierce. There is a history of mental status changes, development of dementia related to long-term dialysis. It alters the immune function. So there are some fairly significant issues. And again, end-stage renal disease really is when there has been a truly significant, overwhelming loss of kidney function. And it's the toxins that are building up, the uremia, that really forces the need for a renal replacement therapy. And these, again, headaches, fatigue, really alter, or I should say decreased mental status. People are very fuzzy because of the buildup in toxins. They have a significant loss of appetite. They don't like the taste of food, in addition to the nausea and the fatigue that comes with it, shortness of breath, and all of these are signs and symptoms of uremia. So once a patient is on the continuum of chronic kidney disease, almost 50% of the patients will progress to needing dialysis, or, if you will, renal replacement therapy. So being diagnosed with chronic kidney disease, even at stage 1 or stage 2, is a fairly significant harbinger of things to come, if you will. And again, once your GFR is down below 15 mils per minute, that's really significantly decreased renal function. We need to use dialysis to get rid of the toxins and the wastes. Dialysis helps control blood pressure. And there are 2 different kinds of hemodialysis. Excuse me, I should call it dialysis. There are 2 different kinds of dialysis. There's hemodialysis and peritoneal dialysis. Again, 40% of dialysis patients have diabetes. So again, highlighting why keeping control of your hemoglobin A1C and keeping control of your daily blood sugars is so important. All sorts of research is being done to try to increase the number of options for dialysis for end-stage renal disease patients. They're even looking at regenerating kidneys using stem cells for that purposes. Trying to really, I think of what the size of a dialysis machine was when I first graduated for nursing school to what the size is now. And so again, trying to make that technology smaller, more portable, easier to use is really important. Some of this stuff we've talked about before, some of this stuff is a review, but hemodialysis, you need to have access to execute hemodialysis. And we put in an AV shunt or fistula, and failing that, they can put in a dual port access that is external to the body. We usually say those are temporary, but again, with so many patients having such significant vascular disease, needing renal replacement therapy, we're seeing a lot more of those different external catheters being used for dialysis access. Peritoneal dialysis, again, is a port catheter, if you will, that's placed in the abdomen so that a fluid flows into the peritoneal area. Via osmosis and diffusion, the toxins come out. We drain the fluid, and that is essentially an exchange, getting rid of the toxins and excess fluids.
Carolyn, I have a question.
Yep.
On the last one. So is the peritoneal dialysis, is that like the third space? Like, is that interstitial fluid, or what are you getting?
So you put in a peritoneal dialysis fluid that has a prescriptive concentration of sodium and other electrolytes, James, and that concentration is going to lead fluids to come out again via osmosis or diffusion into, again, the peritoneal space, and you can get rid of excess fluid like that.
Interesting. Cool. Thank you.
You're welcome. So hemodialysis, the standard in this country is 3 times a week. Once your routine has been stabilized, you are either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, unless something changes at your center. You are hooked up to a machine, says here 2 to 4 hours. I'm much more familiar with the 3 to 4 hours. I don't know anybody, I've not heard of people being hooked up for less than that, plus travel time to your dialysis center, to and from your dialysis center, I should say. You hook some tubing up to either your AV fistula, your AV shunt, or your external access, and blood flows out of the body through the machine, ends up filtering out toxins and fluids, returns back to the body cleaner than it was. And over that 2 to 4 hours, the blood circulates, I think it's 4 or 5 times, so to get the right level of cleanliness and get rid of the right amount of toxins and fluid. And again, this is all, both the peritoneal dialysis as well as hemodialysis is managed by the nephrologist, the specialist in kidney disease. And again, I had this conversation, I can't remember with which group. So there are two kinds of physicians that work with kidneys. There's the urologist and the nephrologist. What's the difference between those two specialists?
Is urologist like more after the kidneys, like all those structures?
There you go, Katie. A urologist is a surgeon by training. They've done their general surgery and then their urology training, and they're much more about the structures and coming up with frankly, a surgical solution. So obstructions and things like that are their business. If you need repair to the ureters, the urethras, or anything like that, they're your peeps. So what does that make a nephrologist?
They're more like internal medicine with a focus on the kidneys.
Exactly, Jen. They're a subspecialty of internal medicine. They've done an internal medicine residency and they've done their fellowship in nephrology. And they're all about the function of the kidneys. Good job. So your patient with end-stage renal disease is scheduled to begin hemodialysis treatments. The dialysis nurse should be aware that the patient will be vulnerable to A, urosepsis, B, abdominal pain, C, hypotension, or D, metabolic alkalosis.
Hypotension.
Why do you think hypotension?
They have like sudden alterations in fluid balance with the hemodialysis, and it changes how their blood is flowing through their body. So usually that would either be like, it would deal with your blood pressure changes. And we mentioned earlier that blood pressure was important to monitor. So kind of just went with that one.
There you go. Well, and not only does it alter the blood flow, but a goodly portion of the circulating blood is actually outside of the body during hemodialysis. Yes, it's controlled. Yes, they're trying to replace it with other fluids so you don't get fluid volume deficit hypotension, but you still do. So monitoring somebody's blood pressure during hemodialysis is an absolutely critical function. I mean, I think it's like 1/6 of the circulating volume is outside the body in the machine during hemodialysis. I'm going to go with that's not insignificant, right? And again, who thinks of this stuff? Not me. So there you go. So you can have a temporary catheter. Again, that's that 2-port catheter, whether you call it a Quinton cath, that's a brand name, and I'm sure there are others. But one thing I'm telling you is absolutely true, regardless of the kind of catheter. It is only used for dialysis. It is not touched by anyone but the dialysis team. And if they catch you futzing around with it, I don't want to be you. So unless you're on the dialysis team, getting ready to do dialysis on that patient, leave that dialysis catheter alone. And it won't be hard to recognize because they usually wrap it up so that you couldn't get at it unless you had scissors and a half hour to peel it all off. Okay? Don't be touching it. Or you could have an AV fistula. So an AV fistula, usually in the arm, but we have to check the patient's circulatory and the strength and of their veins and their arteries. But a surgeon will go in and they will take the end of a vein. Well, they'll surgically create an end of a vein, take an end of an artery, anastomose the two together, and so now you've got a mixing of arterial and venous blood. Now we know, how would you describe the difference between a vein and an artery, like structurally? What do they need to do? How are they different? Somebody talk about that, please.
Veins are.
Arteries,
Oh, sorry. Go ahead.
sorry, arteries are generally thicker because they're it kind of moves the blood along, whereas the veins use the valves, so enough pressure goes to a section, and then one-way valve pushes it back.
Yep. So your arteries are rubbery, stronger, a little thicker. Veins are a little more delicate. It's a more passive system. So now that we've got this arterial blood mixing with this venous blood, it's literally going to drive the veins crazy, and they're going to get strengthened and toughened over time. And I think many of you have seen a dialysis fistula. I think we've talked about this before. So you will be able to find it on the arm. And again, over time, how do you assess a fistula? As the bedside nurse, how do you assess that fistula each day?
You feel for thrills and you auscultate for bruits.
Yep.
And you ensure patency.
Well, you don't, that helps. That's an external sign of patency. That's exactly right. And again, because you've got all of a sudden got turbulence of the blood flow as it's moving from the artery to the vein, you're going to feel for a thrill and listen for a bruit. That's exactly right.
We let Linda listen to my little brothers over the summer.
But again, this being natural tissue, it takes a long time. So you need to plan ahead if you want to do an AV fistula. It takes 3 to 6 months for it to mature for use as an access for dialysis. Let's say patients' veins and grafts aren't that great. Maybe we don't have a ton of time. You know, I'm sure there are other reasons that you might choose to do an AV graft. But again, you're sort of artificially ending an artery and a vein. You are putting in a graft between those two, anastomosing the ends. These are much quicker to mature, 2 to 6 weeks versus 3 to 6 months. And they are effective as well as access for hemodialysis. And again, you're going to see a change in the anatomy of those areas, and you will still feel for a thrill and listen for a bruit at an AV graft site as well.
Carol Ann,
Yes.
this may be like a silly question, but so could you explain the purpose of forming the fistula and creating that? I might be jumping the gun here too, but
No, I don't think you are. I don't think I discussed this. So the way the dialysis machine works, yes, there's a pump that helps pull the fluid out of the body, but by connecting the dialysis to an AV, let's go with fistula this time around, it ends up that you don't have to use as strong a pump, which means there's less damage to blood cells and things like that. So by getting the body to help the process of dialysis, it ends up being safer. I know that's an overly simplistic explanation.
No, that's fine. But then
The way I've
does
understood
that
it.
does that create any problems because then the oxygenated and the deoxygenated blood are just continuously mixing?
Well, what you need to make sure, and this is jumping the gun just a little bit, but it's worthy. You have to make sure that distal to the fistula or the graft, you're still supplying that limb with blood. So again, it's typically in the lower arm, although again, depending on a person's arterial health, it could be higher. But you still need to make sure the fingers are being supplied with oxygenated blood. We really don't want those to crumble up and fall off, you know?
That makes sense, but it doesn't like screw up the overall circulation of the body. I'm assuming.
No, it doesn't.
Interesting.
Yes, I agree. And I'm not sure I wholly understand that, but I do. I think that it's funny. Here, funny, ironic, but I look at some of those fistulas and they really get so big and not sclerosed isn't the right word, but really thick, and you kind of can't miss it, sort of thing. But yet they're really working with relatively minor arteries and veins. But yet, again, just by mixing the two or anastomosing the two, you really do get quite the physical change in the tissue.
Yeah, I actually had a patient this past week who had a fistula in her left arm, and it was very noticeable. Like there was obvious scar tissue on the outside, and the thrills were way more evident than I had anticipated.
Well, that's good. Made it easy for you to find it. That's fabulous. But it is, and again, I go back to thank goodness there are people who are smarter and more creative than I, because this really is a life-saving. How long had she been on dialysis?
So she wasn't my patient for the day because we were shadowing it. She was just one of the many patients, but she had been on, and Jamila might know a little bit more because she also had her, but she had been on dialysis for quite a long time from what I understood. She had a lot of complications. She had a lot going on.
They always do almost.
But she was in her, like, I want to say late 80s, and I think she had been doing it for quite some years.
There's a fair bit, interestingly, there's a fair bit of research that a patient who starts dialysis after the age of 70 actually doesn't live any longer than a patient who refuses renal replacement therapy.
Oh, wow.
The only difference is that the patient who does start dialysis, which is typically the therapy offered to that age group, they almost, like 97% of those patients die in the hospital, versus patients who choose not to start can choose where they want to die versus being forced into the hospital.
That makes sense. I'm sure they would have a better quality of life up until that point too, because they have less side effects.
Well, you know, I've talked about my mother who ended up with end-stage renal disease at the end of her life, and the physicians really recommended she started dialysis, and she chose not to. And I remember the nephrologist he had been a second-year resident when I was a new grad, so I'd worked with him forever. Great guy, love him to pieces, excellent physician, wicked smart, all that sort of stuff. So my mom goes in and she's like, no, doctor, I just don't think it's for me. I think it's really important that I'm at home and I get to stay with my grandchildren and blah, blah, blah. He's like, well, okay, Mrs. Wetmore, that's fine. Hey, can I talk to you? She's going to see you out there. I want to talk to Carol Ann for a minute. So as soon as my mother left, he looked at me, he started screaming, she's going to be dead in 60 days. Are you crazy? And I'm looking at him going, what the hell? Did she act like she was coerced? Did she act like she doesn't know what she's doing? Did you get the sense she doesn't understand the consequences of this decision? Because you've got to go convince her that, yeah, I'm right on that. And of course, and again, the risk of thinking you have a crystal ball is, 2.5 years later when she finally passed away, not so much in the 60-day range, and he came to her wake and he's like, well, I guess it wasn't exactly 60 days, was it? No, I don't think it was. But again, that was her choice. And again, I'm sure there were other people in that same situation that would have been done in 2 weeks. Who knows? But that's for an individual's decision, not necessarily ours. So here I have these under temporary catheter, because again, theoretically, this external, whether it's a Permacath, Quinton, again, those are brand names, whether those have always in the past been traditionally used as a temporary bridge while a fistula or a graft is maturing. But more and more I'm seeing these being used as long-term access for dialysis because of generally poor arterial and venous health in dialysis patients. They're put in like central lines. These need to go into large veins. In these cases, there is no access to arterial blood flow. These are always placed in veins. So they don't get the help from the arterial push, if you will, which is why it needs to go into a very large vein, so that as the machine is pulling it out, there's less damage to the venous tissue. They're not as advanced as far as central lines are, which are typically advanced to when they're right outside of the right atrium. But again, they need to be in those same really big veins.
Yeah, sorry. We put in a queen cath yesterday into one of my patients because she was undergoing apheresis, which is it's like similar to dialysis, but just extracting like plasma because she had CAPS, like the catastrophic anti-phospholipid disorder that caused like a bunch of little blood clots in her body.
Yep.
And yeah, the tubing was a lot smaller than dialysis, and they just did it at the bedside.
Yep.
Surgical, sterile procedure.
They're doing a lot more things that, when I say mimic dialysis, meaning that there's that a machine is attached to the blood flow of the body. The blood flows out of the body and undergoes some kind of treatment and then is returned to the body. And in some cases, they're removing antibodies and plasma with apheresis. In other times, they're getting other sorts of treatments. Dialysis, they're removing waste products as a substitute for kidneys. You want to hear really crazy? This is the one time I had trouble. Well, part of the conversation, I still thought he was batshit crazy. But when the president was talking about ultraviolet lights to treat the blood to mitigate coronavirus, this was back like April-ish, about the same time he was talking about hydrochloroquine treatments. That sort of treatment is not, whether it's effective or not, that I don't know. They would have to do research on that. But subjecting blood to different light treatments and things like that is not unheard of. There are different things that are treated like that. So I'm sure somebody was doing a research study. And while that was part of, I'm sure many people took that to be, some people took that to be crazy talk on his part. That was some of the less crazy talk that he's uttered before. But again, it's really important to note with these temporary or these catheter accesses They are only touched by the team who are using them. We don't change the dressings. We never access them. They're there. You don't be drawing bloods off. Just don't make like they're not there. The only time you're going to notice them is if you find that the dressing is hanging off and they're bleeding from it. You're going to reinforce that dressing, and then you're going to call the team to let them know. But you're not fixing it or mucking around with it. Very limited work you do with these, unless you're on that treatment team. Jack, is that pretty much what you heard about that catheter?
Kind of, but the attending like asked my nurse to do the like the wrapping and bandage of the catheter, because he said that like they would be the ones dealing with it, and that they may be actually more like skilled with applying the bandage to it.
Yeah, the surgeons aren't good at. Yeah, they're not. Yes, that I understand.
Yeah, he just said that the nurses are like, they may be specific to the way they'd like it done. So he just asked Brian if he wanted to, and he went and grabbed sterile gloves and did it.
Yeah, but I suspect the team that comes up to do it will manage it over time.
Mm-hmm.
Okay, and then here's your sort of a picture of the AV fistula and graft. Again, the artery is essentially the out, and the vein axis is the back in, if you will. The AV fistulas, which is a naturally created fistula, have the fewest complications. They're more resistant, as it says here, to infection and clotting. But again, not everybody's arteriovenous health allows for an AV fistula. Protecting that limb is really important. You don't do blood pressures, you don't do IVs on that arm, you don't do blood draws. Most patients are wearing a, or even as you said, was it Katie, you said that it was pretty obvious, or was that Kelly that said the fistula was pretty obvious? But when they're in the hospital, there's usually signage that's the to lay off, no blood draws, right arm, left arm, whatever it is, no blood pressures. That's something that's always passed on in report. And it's something you're always assessing to make sure you are feeling that thrill and hearing that bruit. If it does start to bleed, again, remember that there is arterial access there, so you need to apply pressure. And you also always check your pulses and your cap refill distal to the fistula or the graft. You've got to maintain the function of that limb, and that requires adequate arterial blood flow all the way down to the tips of the fingers as well. And then, of course, you worry about infection. You are sticking needles into that 3 times a week. There is certain risk there. They're called exchange sets now. Does anybody work in dialysis? That was last year's class. I had 2 folks who were dialysis techs in last year's class. So they were very helpful in this lecture. Oh, the halcyon days. But the exchange sets that go into a dialysis machine are actually reusable. I don't know how many sessions they can go, but they need to be stored properly. They need to be cleaned properly. But I have to believe that when you're reusing something, there's a potential risk for infection. And of course, there's always faulty aseptic technique. So you're not only assessing the thrill and the bruit, but you're looking for signs of hemorrhage. You're looking for signs of infection at the insertion sites. That's all really important and part of the ongoing assessment as well. We need to make sure the patient understands that they need to protect that arm and protect that access. That it's not just us, but they should not, try to not bump it or create too much trauma to that limb as well. They need to know what to look for after it's been accessed, once they get home after dialysis, to check to make sure there's no bleeding or leaking from the site. And that they should keep that skin clean, prevent it from over drying. You don't want dry, flaky skin that is going to lead to more skin complications. So we want the skin to be supple, if you will, but we need to keep it clean also. They shouldn't wear anything, certainly nothing that's going to create a tourniquet above the site or below the site for that matter. Make sure jewelry is not excessively heavy on that arm. They should not use that arm for carrying heavy objects. And again, they need to really protect it to make sure there's no damage done to the fistula as well. There are home hemodialysis programs. I don't think they are overly popular or popular in highly populated areas, but you go out to areas where population is more sparse and travel distances are of greater distance and time, and there are definitely home dialysis programs. They tend to be a little bit faster in terms of how long patients are connected to the setup. Other advantages of hemodialysis is they are better at creating diabetic control for diabetic patients. They're very good and very fast at removing excess potassium. So if that's a problem, it's highly effective for that. Because there's less loss of protein through the plasma, there's less risk for skin healing, albuminemia, or I should say hypoalbuminemia, and nutritional status is easier to maintain on hemodialysis. It can also lower triglycerides as well. And you can get temporary access very quickly. It's as quick as putting in a central line. It can be done in minutes, and you can have them hooked up by dialysis in next to no time at all in an emergency. Again, vascular access with the use of the temporary catheters for long-term access, this is less of an issue. But patients are still on strict diet and fluid limits. They do use heparin to keep blood flow going during the treatments. There is some blood loss in terms of having some blood outside the machine in the filters, and even when you're shutting down the process, there is some blood loss, and these are patients who are already prone to anemia because the problems within the kidneys. You need trained personnel unless it's a home dialysis program. And you'll again, if this is something that interests you, there are relatively few companies that do dialysis nowadays. DaVita is the big one, and the other one begins with a P. It's not going to come to me. I'll think of it later. But they almost always have RN positions posted. But the real issue is, and again, I think I've spoken to this before. So patient goes for dialysis today. Today's there, what day is it? Thursday. So they're a Tuesday, Thursday, Saturday person. So they have dialysis today. Between the travel time, the time hooked up to the machine, it's basically a 5 to 6 hour commitment. And they get home and they're tired. This is one of those medical procedures that even though they're laying there seemingly doing nothing, they're exhausted after their dialysis treatment. The next day, they feel pretty good. They had dialysis yesterday. They've got better energy the day after. So that's one of their good days. Saturday, they come back for dialysis. Again, they're pretty tired afterwards. They tend to rest afterwards. Sunday's a good day. Now, Monday, they don't go for dialysis. That's their off day. During that day, they tend to be tired, more nauseous, have some of that fog that comes from elevated toxin levels. Thankfully, Tuesday, they go for dialysis. So they're exhausted on Tuesday. So all in all, there's really 2 days a week where dialysis patients say they're feeling good. And again, I ask you, if you've got other experiences or had patients talk to you about this, please feel free to share. But it is not like, oh, I've started dialysis, everything's Jake, I feel great sort of thing.
Ended up being interesting with the things that are going on with school now with COVID, because like my mom had to kind of fight with the school and using the social workers and stuff between the school and the hospital because of the way they've split up like the school days, like when they would actually go to school.
Yes.
And how they split it up with like the names and stuff to like try to fight for him to be able to go to school at least 1 day a week, like during his senior year, because he didn't fall on the right day with the day that he would feel, like you said, like have some energy and feel like, enough to be able to focus in school.
And he could
So
pay
it's-
attention and participate in all the things that you hope of a student. Yeah.
Yeah.
Thank you. So just like any patient, when they're inpatient, unless you're in an ICU or there are other, usually infection control issues, most patients go to a dialysis unit in the hospital for dialysis. So when they return, it's like a patient returning from any other procedure. You're going to go visualize them. You'll have gotten a report. You're going to do a head-to-toe assessment, or at least a focused assessment. You're going to check their access, take their vital signs. You want to make sure that they actually look like the report you got, so that you have a baseline upon their return from their procedure. We worry about hypotension, mostly bleeding from the site. And we want to make sure there is still a bruit and a thrill in that area, and that there is no clot that's formed when they removed the needles or the access, if you will. And again, then you check the circulation distal to the fistula / graft to make sure that there's good blood flow to the very ends of that extremity. There is some potential for bleeding. There's potential for thrombosis. There's infection. And then again, steal phenomenon is what happens after usually it's more common immediately after a fistula or a graft has been placed. And even though they don't use the major artery or veins for the graft fistula placement, it is possible that circulation to the distal part of the limb decreases and you end up getting vascular insufficiency, which is a problem and usually needs to be treated surgically. Why don't we take a a little break here. Why don't you guys come back at 12:30? And we'll start off with peritoneal dialysis, okay?
Okay.
I'll be here if you need me to want to ask questions.
Thank you.
Did you want to stop the recording?
Oh, thank you. Recording. I don't think there's anybody in the waiting room. You'll let me know if there is. We're going to start talking about peritoneal dialysis. So peritoneal dialysis, again, you still have a catheter placed that goes into the peritoneal area. You have something called dialysate, which has a specific concentration, and that flows into the peritoneum, sits there for a while, and via osmosis and diffusion, out comes waste, out comes excess fluid, etc., and then it drains out, and this becomes the waste product. It's interesting, to say the least. How'd that happen? Wait a minute, where am I? Oh, I went too far, sorry. Done. All right, so the waste and the excess fluid leave the body when you drain the dialysis solution. You throw that out into protected garbage usually down the toilet, and then protect the bags as waste. And that process is called an exchange. And usually the dialysate should flow into the peritoneal area very easily without any problem, like your free-flowing fluid. It sits for usually about half an hour, and then it flows out. So the whole exchange process should take about 40 minutes. I say about. The time the fluid is left in the abdomen is called dwell time. And so the concentration of the dialysate used is part of the prescription. The dwell time is a prescription as well. And how many times or how many exchanges per day is also part of the prescriptive process by the nephrologist. So again, osmosis and diffusion is the way this worked, with the peritoneal membrane being the filter, if you will. The higher the percentage of concentration of the dialysate, the more excess fluid is removed. So somebody who's getting a 1.5% dialysate, this is a person who doesn't have much of a problem with fluid balance. You're not taking a lot of excess or extra fluid off. But somebody who's getting 4.25% dialysate, you could be taking as much as 1 liter off with each exchange. So you can see why and how that percentage of concentration is important in terms of your patient's fluid balance. And again, the wastes come across that permeable membrane as well. What wastes get removed? BUN, creatinine, potassium, phosphorus. Those are the sort of, I'm talking waste products that I'm talking about. And again, how often those exchanges are done is determined by the nephrologist. Could be 4 to 6 times a day. Sometimes it could be as often as every hour. so that you end up doing 24, if you will. Now, that's something typically done in the hospital. We'll talk about what happens when patients get home. The catheter is typically called a Tankoff catheter. I'm sure there was a Dr. Tankoff who developed this. And that catheter is left in place. It is not removed. So maintaining the sterility of the catheter is kind of critical. You also want to make sure there's no signs of infection around the insertion site. But again, when you are accessing that catheter and hooking up the dialysate and the drain bag, making sure your technique is aseptic is really important. Some of the advantages, you can have patients with terrible vascular health, but we don't need vascular access. We're using the peritoneum for this. There are less dietary and fluid restrictions because it's being done every day. There's no off day. It is literally done every day. This is much better at maintaining blood pressure control for patients. And while it may be hard to understand how and why it works, the process itself is actually quite straightforward. So it's viewed by patients as not as complicated as hemodialysis. Again, it can be done at home. There are typically fewer cardiovascular problems, and patients are often able to work every day. It's easier to manage for patients with diabetes. It really is a pretty good, not pretty good system. It's an excellent system. But here are some disadvantages. There's obviously a risk for peritonitis, and that is not if you end up with peritonitis, that's not a small problem. You do end up with increased losses of protein compared to hemodialysis. Some patients complain of chronic back pain with peritoneal dialysis. It is harder to manage your blood sugars with peritoneal dialysis, so that is obviously a concern. Adjustments can be made in basal rates and your coverages, but again, there are greater risks for hyperglycemia. You need a surgical procedure to place the catheter, and you worry about the catheter migrating or moving. Patients who have had a history of abdominal surgeries and or aneurysms. So if you have a lower aortic aneurysm, a renal artery aneurysm, or a lower aortic dissection, you are not eligible for peritoneal dialysis. The other thing is, and this is quite operational, but these supplies are delivered once a month. So if you're doing 6 exchanges a day, that's usually 2 liter, you need 6 2-liter bags per day times 30 days. So that would be like having 180 2-liter bottles of soda. Not everyone has that amount of storage space, right? And again, it's got to be done daily. So we talk about once patients go home, and then we start calling it continuous ambulatory peritoneal dialysis, CAPD. And so if somebody needs to do it literally around the clock because just doing it at night is not possible or not optimal for them, or I should say not at night, but while they're sleeping, you can do it on a continuous basis. All you need is something to hold the bag a little higher than the abdomen. You connect it up, you flow the fluid in, stop it, let it dwell for however long it needs to dwell. When you're done, you open it up and you drain out the dialysate. The vast majority of people do their peritoneal dialysis while they're sleeping. They have a machine called a cycler. They set up X number of bags, however many cycles they need to do on their overnight, and the machine will literally flow it in, set a dwell time, drain it out, then the next one initiates. So the machine acts as the cycler and all. You set it up before you go to sleep, and the machine should handle it. Obviously, alarms go off when something misfunctions, when pressures are high, when something's not draining, but it does all the measuring, all the weighing, all of that for you, and you just record those numbers to keep track of what's going on. And again, in today's world, I suspect these have become quite intelligent, where it tracks the numbers and probably sends it via Wi-Fi to wherever it needs to go from a clinical perspective. So again, that nephrologist is making a lot of decisions regarding peritoneal dialysis in terms of the concentration of the dialysate, how many milliliters are infused with each exchange, how long is the dwell and the time between exchanges, should any medications be added to the dialysate. If there's a problem with fibrin starting to form in the tank-off catheter, they might put a couple of units of heparin into an exchange bag. Maybe not every bag, maybe one a day, maybe two a day. Maybe there was a little bit of a sign of infection. And remember how we talked about with cystic fibrosis patients, sometimes they get their antibiotics aerosolized because the infection is very limited to the lungs. And so you don't have to administer antibiotics to the entire body if you aerosolize them. Sometimes if we're concerned about a budding infection, we might add a little antibiotic to our exchange fluid. Again, before the infection becomes systemic, we might be able to treat it directly by adding it to the dialysate and treating it within the peritoneum. Sometimes we can put a little, I think we can put insulin in the dialysate. What else have I put into dialysate? Certainly heparin and antibiotics are the most common. And don't quote me on the insulin. I need to look that up, but somehow that's, I think that's possible also. But again, all of those are determined with a prescription. So every setup comes with the bag of dialysate, typically 2 liters, but you can order other sizes. Lots of tubing, one going to the full bag and tubing going to the empty bag. And both of those tubes have clamps on them so that you can start and stop things. And then this is typically an iodine soaked cap that's going to attach to the end of the tank-off catheter, which you see on the lower right there. Again, those are often iodine soaked catheters to help preserve the anti-infective integrity of those ends. Again, so you need a hook to hang the full dialysate bag up slightly higher than the abdomen. And then this area right here, you see that little green area on the tubing? We call that a frangible. There's a little plastic knot in there that keeps the fluid in the bag. Once everything is all set up, so this bag is hanging higher than the abdomen, this bag is in a basket, usually a wash basin in the hospital, on the floor, empty. This end is connected yet, but because you want to prime the tubing, you bend that frangible, and that allows fluid to prime the tubing. And it's that frangible cap in there that keeps the fluid in the bag. But again, you're going to want to prime that tubing to get the air out, because we don't want to run air into the peritoneum in general, and injecting air into the body, whether it's into a vein or the abdominal cavity. We'll leave that for other folks if that's okay with you. But again, once you've primed the tubing, connected it to the patient, then you can run this fluid into the abdomen, sits there a little while, and then when the time comes, you clamp this off, and you open up this clamp, and it drains right into the emptying bag. Has anybody seen peritoneal dialysis yet, or had the pleasure of doing peritoneal dialysis? Your day will come, trust me. So you need to check every bag. It's nowadays they're usually being scanned just like another medication, and so you want to check that you've got the right expiration date, or it's not expired, I should say. Is it the right volume? Do we have the right concentration? It should be clear. You need to differentiate. Again, it comes just like an IV bag in an outer plastic bag. There may be some fluid inside the outer bag, but you need to figure out, is the bag leaky, which means you throw it out, or is it just condensation? You want to make sure those frangibles that I spoke of, there's one, hold on. I don't know if I can get back there, but there's two frangibles that you want to be intact so that fluid's not running through them. And if you have any doubt, like anything else, you throw it out and get another one. These should also be at least at body temperature. I mean, you're putting 2 liters into somebody's abdominal cavity. You put it in too warm, you're going to alter the patient's blood temperature. If you put it in too cold, it's really uncomfortable, and you alter their body temperature. So we keep these in warmer so that they're body temperature, not room temperature, body temperature. Again, it says room temperature here. It is usually kept on the warmer side, but you never ever use a microwave. You're either kept in a warmer or kept in a warm fluid solution. You make sure that the abdominal cavity is empty before you flow in your dialysate. So you want to make sure that everything is drained out before you put new in. And everything gets weighed. That is how you calculate how much fluid you're taking off the patient. Or conversely, are they retaining dialysate? You weigh it before you flow it in, and then you weigh it after it drains. And that's part of your documentation. You look at your effluent to make sure what color is it? You know, slightly yellow, like that hay color that urine looks like, not uncommon. Okay. Green, brown, bloody, not okay. So we're always documenting that also. And patients who have been doing peritoneal dialysis for a while, like many patients, tend to be very helpful, very supportive. It's good to let them participate in the process. Number one, they often like to show off their skills. Number two, they often have their own way of doing it. And if they're maintaining aseptic technique, that's good. The problem usually comes when they want to show off their skills and their technique is less than pristine. So then you need to figure out how best to approach them to try to improve their technique. That can be a challenge, you know? So some of the biggest challenges with peritoneal dialysis is when it doesn't infuse or it drains with difficulty. And a lot of times it's because there's a kink in the I have to admit people. There's usually a kink in the catheter, if you will. I already talked about sometimes there's a little fibrin clot maybe. Red blood cells, you want to manage their fluid status. Hope, machinery, equipment can break down. And again, infections like peritonitis are a potential risk with peritoneal dialysis. If you need, you're going to want to recommend collecting a sample. If your effluent becomes cloudy, if there's abdominal pain, that's always, you can certainly send that for culture and sensitivity and other analysis as well. As I said, heparin antibiotics are often added to the dialysate. And again, adding those medications, you need to scrub your hubs before you administer them. You're administering medications, so they need to be signed off the way all medications are signed off. You need to label that bag that there were medications added to it. All of the same procedures you would use for an intravenous medication or any other medication need to be followed. You're always assessing the catheter area for infection. Usually in terms of care of that site, it's usually sterile saline. There's not usually a dressing there. Again, you have to figure out what that patient is doing. And in the early days, they may use a gentamicin ointment while it's healing. But again, most times, if it's a clean, dry, and intact site, there's no additional dressing, no additional ointments. We just want to keep it there. But we don't want the catheter being pulled out of place, so you always want to anchor that catheter. I'm not going to say the same way you would an indwelling Foley catheter, but you definitely want to tape it up and you want to protect the patient's skin and you want to protect the positioning of that catheter as much as possible. So some of the things, most flow problems can be fixed by a couple of different things. Number one, make sure the clamps are all open. I've been in situations where we've sort of all stood there and looked at it for 5, 10, 15 minutes and then figured out one of the clamps wasn't open. Embarrassing, to say the very least. Hopefully the patient was sleeping. Make sure your frangibles have really been broken fully. Make sure nobody's laying or standing or kinking one of the tubes. Have the patient change positions. If they're laying down, sit them up. If their arms are down, have them put their arms over their head. Twist, roll to the right, roll to the left. Do the hokey pokey and turn yourself around, if you will. But again, patient changing positions can go a long way. Have the patient cough, create a little bit of extra pressure internally. All those things often help. And then one of the biggest problems in terms of outflow is constipation. So we want to make sure patients are having regular bowel movements, and if they need to be on a regime to make that happen, so be it. But constipation really is can complicate the outflow of peritoneal dialysis solution. So you're planning care for a patient who has peritoneal dialysis. Which are appropriate nursing actions? Monitor serum glucose levels, report cloudy dialysate returns, warm the dialysate in the microwave, assess for shortness of breath, check the access site for wetness, or maintain medical asepsis when accessing the catheter insertion site. Huh. Let me put it like that. Are there any of those that you would not check in a select all that applies situation?
The microwave one?
C.
That's easier than saying A, B, D, E, and F, right? Now let's hope, yes. So we never put it in a microwave. Let's hope that's correct. Oh, we don't like F either. We should maintain surgical, not medical asepsis. I always trip up on those. But all the others we talked about. All right, patients need to know the signs and symptoms of both infection, so fever, changes to the effluent, they should be able to recognize redness or discharge from around the catheter, cloudiness of the dialysis, of the effluent, as I said. And if it looks like that catheter cuff has changed positioning or been pushed out, they should notify their clinician. Again, these patients, look who's here, guys. He had to say hello. Hi, Allie. Everybody's there looking at you. Good boy. So again, patients with chronic kidney disease are at risk for fluid overload. So we know daily weights are critical intervention. They should be weighing themselves and all those things we learned in the spring. Same time of day, wearing essentially the same clothes. Make sure they're using the same scale as much as possible. When you're weighing patients in the hospital, know your hospital's policy for how do you take a bed weight, if you will, or if they're standing, try to use the same scale. And again, as much as possible, make it the same time of day. And then look at the results and make sure it's comparing it day to day to see if there are any changes. Patients, particularly on hemodialysis, should limit fluids. They often don't have an actual fluid restriction written, but these are not the folks that are just downing whatever comes into their mind. They should also have a dietary consult. They need monitored potassium, monitored phosphorus, and frankly, low sodium. And so again, here's a picture of a meal tray. Anything there that stands out as not being exactly right for a patient with chronic kidney disease?
The banana's high in potassium.
That is correct.
The Coke, too much sugar.
Again, correct. You've got some prepared food over here. So it looks like a pudding cup, if you will. We know in general prepared foods are not ideal for patients. I forget about milk and phosphorus. But on the other hand, their need for calcium may override.
Be limited.
Yep. And again, that's an awful lot of carbs. We don't know what their underlying cause is or if they have trouble with their blood sugars, but that is a carb-hearty meal. Is that fair to say? All right. So other medications you're going to see commonly in patients with chronic kidney disease and things that you want to think about how they're going to interact with hemodialysis are your antihypertensive medications, some antibiotics, other vitamins. And again, you don't usually hold antihypertensives. You may time them differently because of dialysis. On the other hand, antibiotics, particularly if they're getting them intravenously, are often given during dialysis. So you just have to question it. Not the by mouth ones, but the intravenous ones are often given by the dialysis nurse. And again, the dialysis staff can be very helpful in making those determinations. Phosphate binders, they may start with some Tums, which are over the counter, and they may move to the Renal and the Renal, which are prescription. And those are taken before eating meals so that they catch the phosphorus on the way in, if you will. And they're usually taken before each meal of the day. You need to question any potassium supplement ordered for a chronic kidney disease patient. And again, as I say, doesn't mean you don't give it, but you need to be sure that we're really aware of what their kidney function is and what is the ability to get that potassium out of the patient if need be. Fleet's enemas are very high in phosphorus. So we don't administer Fleet's enema patients to end-stage renal disease. We talked about how K-Xlate is what we use to treat hyperkalemia, but we need to make sure the bowels are working because, again, in most cases, they take it orally, although it can be given via an enema also, per rectum, I should say, not enema, per rectum. But it does rely on a working bowel, so we need to make sure that that is working. In terms of kidney transplantation, or any time we're talking about a solid organ transplant situation, there are not enough organs to go around. There are about almost 100,000 patients waiting for a kidney now, and yet only about 25% of those will ever receive a kidney. The 1-year survival rate on kidney transplants, even with a cadaver kidney, is 90%, and with live donor transplants, it's 95%. So again, this has been a very successful, very effective therapy for patients with end-stage renal disease. The advantages are, of course, that you are no longer tethered to any sort of dialysis process, whether it's hemodialysis or peritoneal dialysis. And it ends up being less expensive over time compared with dialysis. When you're looking at recipients, some of the contraindications are disseminated malignancies, untreated cardiac disease, chronic respiratory failure, extensive vascular disease, chronic infection, and unresolved psychosocial disorders. Many of those issues make you a very poor candidate for surgery of any kind. So it's not particularly surprising that those would be on a list for something as when a resource is as limited as an organ, but nonetheless, usually unresolved psychosocial orders. So that sort of gets to your question a little bit, Robin, a little bit. There are certain surgeries that are often done before the kidney transplant, like a coronary artery bypass, cholecystectomy, even nephrectomies. Again, those are all high risk surgery. Well, cholecystectomy not as much, but are high risk procedures, not only from the stress of the procedure, but for infection risk also. And again, they want to have those issues mitigated before they move forward with a transplant and put a transplanted organ at risk for those sorts of procedures. In terms of the donor, obviously their kidney and their physiology is going to be studied extensively. There's going to be lots of laboratory tests checking on the function of their kidneys, making sure that they are in fact healthy people and that their kidneys are doing their job for themselves. Then they're going to be checked for all sorts of chronic infections to make sure that there will be no transmission of infections like hepatitis, HIV, or CMV, because especially once that kidney is transplanted, the recipient will be immunosuppressed for the rest of their life to prevent rejection. So to ensure that the donor organ is not infected with a chronic infection is critical. A cadaver kidney is resourced from people who have passed away who were relatively healthy. Yes, I know they're dead, so clearly something happened. But this is often why people in the emergency services often refer to motorcycles as donor cycles. Relatively healthy people who have an unfortunate run-in with an incredibly hard, immovable object, which results in severe catastrophic brain injury, where the heart hasn't figured out to stop yet, make unfortunately good donors for many solid organs in other parts. And the role of organ donor counselors is they're in the hospitals almost every day. Was somebody telling a story this year in the spring about the organ, that the organ donor counselor was on the unit last spring? Am I dreaming that? I guess I'm dreaming that. Okay. All right. So obviously it starts with the live donor having the nephrectomy performed or having the kidney removed. That's about an hour or so before the recipient surgeon starts. They try to do these things laparoscopically, both insertion and removal, and they're getting incredibly skilled at it. And I think the other interesting thing is that when the receiver, the kidney receiver, it's not put in the same place where the original kidneys were. They place it outside the peritoneal area in what they call this iliac fossa. So it's in a completely different area than usual. And one of the reasons physiologically, my understanding is the kidney is where it is because it gets protection from the ribs back there. So this transplanted kidney is usually getting protection by the iliac crest now versus the ribs. So it's more sort of forward versus up and back, if you will. And there's a picture of it. And they have to attach all the veins and the arteries to make sure the blood's flowing. They have to reattach the ureters to make sure the urine's flowing, things like that. So any sort of transplant, just like a blood donor, we talked about, I mean, there's multiple testing. And with blood, again, the highest level is blood type and Rh factor. When it comes to transplanting organs, I believe there's somewhere around 60 or 70 different factors that they check on for compatibility. And the more factors that match, the less chance of rejection. The only time you're going to find an exact match for all factors is obviously with identical twins. I don't think that happens all that often. But the more factors that match, the less chance for rejection there are. Patients get their hemodialysis the day before, and then postoperatively, as I said, they're immunosuppressed forevermore. The live donor, has a fairly straightforward postoperative care period. We need to make sure that their remaining kidney is making urine. We need to make sure that they're not hemorrhaging at the site. We need to make sure that from an abdominal perspective, they're not getting an ileus. We need to make sure they're deep breathing and coughing to combat against atelectasis. We need to mobilize them to prevent DVTs and atelectasis. And so again, their post-operative care is not particularly unique or different. The recipient, we need to make sure that that kidney starts working. We want to see, is that kidney going to start producing urine and excreting wastes? Oftentimes they put out large volumes of urine, almost as if they're in that diuretic phase of AKI. So again, we're measuring their I's and O's. We're keeping track of their lab values, their BUN and creatinine. It's a combination of, they tend to get a lot of fluid during the operative procedure, and this kidney's had a little bit of a shock, if you will. That's obviously a scar from an open procedure, not much of a minimally accessed or anything. So these patients will have an indwelling Foley catheter. You want to monitor their urine output on an hourly basis, to say the least, and you're watching for signs and symptoms of rejection. Rejection can occur in as few as hours, like 1 hour after it's been placed. So you have to be very vigilant for those signs. Hold on. Yep. As I said, so immunosuppressive therapy, that cyclosporine is old school, if you will. Prednisone, we know, is a fairly strong immunosuppressant also, but they've added many more through the years. You see a lot of tacrolimus, the sirolimus, and all of these others. And some of these do require blood levels, They may be on more than one because they act somewhat differently. And you want them to be immunosuppressed to prevent rejection, but we want the body to still be able to fight off other overt infections. So it can be a delicate balance, trying to figure out exactly where they need to be from an immunosuppressant perspective. Rejection is the biggest fear for these patients, and again, can occur within minutes or hours once it's been transplanted. Pain, fever, hypertension, no treatment when it happens that fast. You just need to remove the organ and they go back to a renal replacement therapy. Acute rejection can start within days or months after transplant. Again, you're going to see decreasing urine production, increasing lethargy, some fluid retention. And this is when they're going to start changing the immunosuppressive therapy, and hopefully it can be reversible at this point in time. And then there are patients who live within a chronic state of rejection. It becomes irreversible at some point in time, but so long as the scarring is not too significant in the kidney will continue to function, sometimes at a decreased level. Again, there's usually a lot of interaction between the immunosuppressive therapy, and that could become a moving target. People with chronic rejection do occasionally need repeat transplants as well. But you need, or renal replacement therapy again. But there are other people living with chronic rejection where it's enough renal function, the balance is okay, and they're making do, if you will. Patients should continue with daily weights. They should keep track of their urine output. They need to eat a healthy diet, and that's whether it's maintaining their blood sugars on a stable level if they're diabetic, watching their blood pressure over time and following a diet that is blood pressure friendly, if you will. They need to monitor for signs of symptoms of infection, not only from their transplanted organ, but again, because they're immunosuppressed, we need to monitor for infection overall. They don't want to damage that kidney with some external blow, so they refrain from contact sports. And again, they need to be educated about what the signs of rejection are. So a patient's waiting for a kidney transplant asks the nurse, what signs and symptoms most likely indicate rejection? And what would be the nurse's best response? Low urine output can be a sign of rejection. Shortness of breath is often a sign of rejection. Decreasing blood pressure or weight loss. What do you think?
Low urine output.
I think you're right. Let's see. Low urine output. Again, really important that they keep track of their urine output on a daily basis. I'm not saying they need to measure it every day, but most people are aware of those sorts of trends, if you will. It also means they need to stay hydrated for the most part. And then the last thing, just as an aside, this has nothing to do with transplant or other things, but we often see patients with renal trauma. You know, the kidney is a solid organ. It can have contusions, lacerations, ruptures, all sorts of things, whether it's from contact sports, motor vehicle crash, falling off your bicycle, falling while you're skating, sledding, or skiing. And so you really want to, again, remember, the kidneys are highly vascularized. It's a lot of blood in them at any given time. A small laceration can lead to significant hemorrhage. And so in the ED, when people come in after a fall, we're always checking the kidneys. We're looking for signs of bleeding. And again, renal hemorrhage can cause hypotension and hemorrhagic shock just as easily as some other major traumas as well. And we're done. All right. I don't have any games this week, but I'm going to post a case study for you to look over just to get your juices thinking. And if you want to ask me any questions about it, we can. Any questions from anything we talked about so far? Well, you'll think of some and you'll let me know. I'm going to stop recording right now. Go away.